If it is 1 in 4 women suffer from such a symptom, it is a huge amount, and the consequence of the impact of the pelvic pain is really heartbreaking.
Today on Patient in the Room, we're talking about something that affects millions of women, the gender pain gap. And today, my guest is Dr. Khaled, a consultant in pain medicine. Dr. Khaled, welcome onto the podcast.
Thank you very much. My name is Dr. Khaled Ayazi. I'm a consultant in pain management with about experience of probably over 20 years.
Can you tell me what a consultant in pain medicine does?
If I just simply explain that every pain, chronic pain, which we describe it as any pain which is more than 6 months, or some people 3 months, because it generally needs about 3 months for any wound or pain to heal. But any pain which continues more than 3 months, or now in some parts 6 months, is called chronic pain. And every chronic pain is not only physical, it is biopsychosocial phenomena. It's physical, it's psychological, and social. So consultants in pain management, they look at every chronic pain in a sort of holistic way of looking at not only treating them physically, but either liaising with a psychologist or advising them on exercises and different aspects of the chronic pain, which affects people of different ages and a great number of the population.
And I'd really like to kind of start this episode by just clarifying something. And I feel like our listeners need to hear someone say it out loud. Is the gender pain gap real? Like, does it exist?
Absolutely. Absolutely. There has been a number of studies showed. A recent one, which was published in 2024, they looked at the 2 countries in America and in Canada, the women when they were attending the accident emergency department. They looked at, and the finding was quite disturbing, that women generally, they received 10% less painkiller compared to men. Wow. They had to wait 30 minutes more to be looked at. And even nurses who were women or female, they recorded their pain score 30% less than what the men. There have been other studies they look at, especially cardiology, say European Cardiology Association. They looked at the referral to the cardiology department for the myocardium infarction or any different cardiac disorders. They looked at it, they saw, the finding was that generally the referral is quite low, but it was significantly lower in women than men. So there are other quite strong studies that shows that the bias is really real. And it is not only among the population, and it is among the professional clinicians, regardless of whether they are women and men. Generally, the pain in the woman or any different disorders or symptoms in women are taken much less seriously than men. That's unfortunate.
And so when I was kind of like looking into this topic a little bit, I'd like to talk about the biology for a second. Does pain actually work differently in women? Like, why is there a gender pain gap?
I think rather than you concentrate on biology, you have to go back to the culture. Traditionally, pain in a woman has been sort of taken less serious because in even medical establishment, it is that women are supposed to have some pain because of the going through the monthly cycle and having a pain. Pain in a woman is something has been taken as a normal. And many, they believe that the women are emotional and they complain more about the pain compared to the men. And and also the research among regarding the pain in the woman is much less than overall research about the pain or any other diseases or symptoms. So traditionally, and unfortunately, this has been ongoing for many, many years or maybe centuries, and it hasn't changed.
And I was actually, I can't remember if it was on the podcast or someone was telling me recently that in ancient Greek times, the word hysterical actually comes from the word hysteria or
Yes.
something, and it's about the womb walking around the body.
Not a womb, but around the body. The name of the uterus, I mean, it is at a womb. And if you look at the medical one, it's called hysterectomy and all that. And that goes to the hysteria. And that goes that because, yes, in the Greek, it went back to the Greek culture of ancient time, that the pain in the womb was because of a hysteria. It wasn't real. So, yes, historically, that's true.
That's crazy. And I guess, like, so when a woman is going to kind of like A&E and their pain has been dismissed, what can that person do when they are in that situation to kind of say like, no, my pain is valid, I am feeling extreme pain? How do they get that seen?
You're looking from a wrong angle. In a sense, let me just explain. I don't think that you just go to the A&E and you will be able to change the culture. That's not something that probably it will end up in the fight or some sort of the confrontation, which is not. I think we have to go back to the establishment, media, social media, TVs, medical profession to come out and then explain this. And gradually this change in the culture takes time. It's not for one woman or group of women going to A&E or going to GP and demand for the improvement in the pain management. This is something that has to come. It has to be through the state. It has to be quite established and standard way. So I'm hoping podcasts like this, gynecologists, urologists, rheumatologists, consultants in pain management, they come forward and they talk about their experiences, which they convey from the patients, how much they have suffered from this. If this come to the fore, I'm hoping that the culture gradually changes and then we come to the point that the gender bias in the management of the pain is not there anymore.
And so you founded the Pelvic Pain Management Service at the Royal Free, a service that didn't exist before you created it. So what does that tell us about how pelvic pain in women was dealt with before you set up this service?
Unfortunately, it hasn't made much difference even after that I started that management of the pelvic pain. Pelvic pain affects about 1 in 4 women in the world. And the number is staggering. Unfortunately, the management of the pelvic pain is very much at the back of the queue, and it is very much dismissed. International Federation of the Gynecology and Obstetrics, as well as the International Pelvic Pain Society, they had a consensus statement which was published in 2025. This was actually a cry to all over the world that the pelvic pain is really being dismissed, very much treated in a wrong way. And a lot of work has to be done. Because if it is 1 in 4 women suffer from such a symptom, it is a huge amount. And the consequence of the impact of the pelvic pain on the humans, both women and men, because subsequently on men, is really heartbreaking. When I started, I had some training in pain management at University College London Hospital. And then when I became consultant, I had a few trips to America and I met 1 or 2 very good physiotherapists, they call physical therapists, who were involved deeply with the International Pelvic Pain Society. So I became interested. And then once I started establishing the pelvic pain, initially the Chase Farm Hospital, but then became a Royal Free Hospital. And since then, I have treated quite a huge number of patients. That system doesn't exist. I think probably beside 1 or 2 other centers in the country, there is no such a dedicated pelvic pain clinic to manage the pain.
If there's no kind of like place for women to go to manage that pain here, what are they doing now?
Oh, okay, it's a good question. Let's start from this point at how the chronic pelvic pain is managed generally or traditionally. Great number, probably over 90% of the patients are referred to the gynecologist. And within the gynecology speciality, Endometriosis is the one which is taken as a chronic pelvic pain. I'm here to discuss this, that the chronic pelvic pain and endometriosis are not the same thing for many reasons. But unfortunately, once patients who are investigated for the endometriosis and they don't reach anywhere, they are absolutely nowhere to go. So let me explain why I believe that the endometriosis and chronic pelvic pain are not the same thing. It is widely believed that the endometriosis is because of the retrograde menstruation, because the menstruation going back to the abdominal cavity, which settles there and become a lesion and become endometriosis, and it becomes chronic pelvic pain. This is not true. There have been a number of studies show that this idea and also putting all the eggs of the chronic pelvic pain in the endometriosis doesn't make sense, and it has been proven it is wrong for many reasons. 1, 90% of the women have retrograde menstruation, means that the menstruation, rather than coming out, goes back to the abdominal cavity, 90%. Only 10% develop endometriosis. So if it was true, and that the theory is this one, 90% of people should have had a woman should have had the endometriosis. Second, there is absolutely no correlation between the degree, place, or amount of the endometriosis or the level of the pain. If it was true, the more endometriosis, there should have been more pain. That's not true. And a third one, which is quite interesting, women who have a laparoscopy and even sort of removal of these lesions within the abdominal cavity, they generally develop, or the pain, the chronic pelvic pain, returns a year later after the surgery, even if the endometriosis lesion are not there. So you're looking at any aspect of this. The endometriosis is a cause of some pain, or cause of pain within the pelvis, but it is not merely responsible or reason to explain the chronic pelvic pain. If you want, we could discuss what are the other causes and then why it is not. But I will leave it to you. That.
I think you just kind of asked my next question there.
Okay. So
if endometriosis is not a cause of kind of pelvic pain, what's like the most common reasons of pelvic pain that you might see?
Again, unfortunately, the cause or the reason for the development of the chronic pelvic pain, I'm not talking about endometriosis, it's not well understood. Okay. Regardless of all the studies have done, the chronic pelvic pain is multifactorial. It is multimodal. It comes from many, many aspects or the sources. Partly it is endometriosis. There is a great part of musculoskeletal, from the muscle, skeleton and all that. And there are other also psychological aspect of it. I'm not saying that the pain is in the brain. I'm saying that beside the physical, there are quite strong association with the physical, psychological, and social aspect, which makes it as a chronic pelvic pain. The recent the theories, which is accepted all over the world, is that unfortunately in some women, when they start having pain within the pelvis, when even it is the short term, there is quite significant remodeling of the nervous system, both at the spinal level and in the brain level. And this remodeling, it causes and changes it to the chronic pelvic pain. Patients who suffer from endometriosis often within a year or so develop interstitial cystitis, or what some people call it, the painful bladder syndrome and irritable bowel syndrome. If it was only endometriosis, these two other symptoms or the syndromes would not have happened. So these are because what we call it a peripheral and central sensitization. I don't know whether you want me to
could you explain what that means?
And all that. So normally when we have pain, anywhere, The structures which are affected are blood vessels, tissues, and nerves. And each one of these structures, they secrete a little bit of what we call it mediators. And they make it a soup. We call it inflammatory soup. And that is called an inflammatory soup. And these inflammatory soups affect the nerve ending. And then it becomes a sort of symptoms or the pain. It is related to the spinal cord. But it is not as simple. The spinal cord, there is a lot of fight between the shall the pain go or not the go, and there are pathways like highways. Some of these pathways prevent pain going up, and some, promotes going up. So that is called when pain at any site is continuous. Then, unfortunately, this inflammatory soup, and that one, it becomes exponential and it becomes self-perpetuating. So what will happen that all the time the signals are going to the spinal cord over there, and they go up to the brain, and then in brain as well, these are amplified. And at the level of the spinal cord, it's called peripheral sensitization, and in the brain, it's called central sensitization. This, we believe at the moment, is the probably major cause of the chronic pelvic pain. Because as I mentioned to you, most of the things that comes physically to explain chronic pelvic pain does not happen in every woman who has endometriosis or irritable bowel syndrome. So there must be other mechanism, which is this nervous system, which unfortunately produces this.
And I guess if it's in your nervous system, are there slightly more holistic ways in which that you could kind of relieve that pain? Excellent
question. Not holistic way of relieving pain. That's, if I go back to when I started, that every chronic pain is biopsychosocial phenomenon. There have been a number of studies. The only way of achieving optimal pain relief for chronic pelvic pain is a multidisciplinary approach to that. Gynecologist, urologist, consultant in pain medicine, physiotherapist, psychologist. Without this, without liaison among these group of the clinicians, the management of the chronic pelvic pain will be absolutely minimal and not effective.
So when I was kind of doing a bit of research around chronic pelvic pain and kind of pelvic pain in general, pain during sex was something that came up quite often. I know that's an issue for a lot of women. What kind of research is there around why that happens, treatments?
Okay, let me start from just step back. Any chronic pain, any pain anywhere will have some effect around the muscle related to that area. Okay. Chronic pelvic pain is within the pelvis. And there have been a number of studies that the muscle within the pelvis over the lower abdomen, they become very tight. There's a spasm, and then develop what we call trigger points. The trigger points are small, not like a nodule, small piece within the taut muscle. And many women and men have it over their shoulders. Probably people who work with the computer quite a lot, dentists and all that. And you could feel that all the time. So this develops within the musculature of the pelvis, within the lower abdomen. Part of the pain during the sex could be because of during that mechanical action, or during intercourse, pressing those trigger points produces quite a lot of pain. That is one. And secondly, is the sex is due to the involvement of the lot of nerves within the pelvis, around the pelvis, which if you go back to which I mentioned about the nervous system, and not only that, in particular involvement of the few nerves, including pudendal nerve, ilioinguinal nerve, genitofemoral nerves. The involvement of these nerves makes vulva, vagina very extremely sore during the sex, and a deep-seated pain due to the involvement of the either muscle involvement. That could be also due to the endometriosis per se. So the combination is that it is both muscular, it is both a nervous system. From the nerves, the combination makes the sex extremely painful. Some women suffer 48 hours after any intercourse.
Wow, that's a really long time to be suffering with pain. Yeah.
The chronic pelvic pain, the number of studies has shown that it generally, unfortunately, reaches to the point that most of women do not involve in having any physical relationship, and that puts significant strain on the relationship. Infertility is also become a quite issue because of the pain and because also the nature of the chronic pelvic pain, the presence of the endometriosis as well.
So if a woman who has suffered from chronic pelvic pain is pregnant, are there any risks associated with birth? And
no, not at all. In fact, pregnancy relieves the chronic pelvic pain. In some cases, it makes it much better. Because remember, endometriosis is estrogen dependent, or it is hormonal dependent. And during the pregnancy, this 9 months of the lack of the estrogen, it helps to reduce the number and amount and also degree of the endometriosis. So pregnancy is good for the chronic pelvic pain. It doesn't mean that it cures. Generally, it comes back, but it is a positive step rather than being hindrance.
And I guess that you can get a lot of drugs that are like, you know, numb your nerves and numb your muscles and stuff like that. Does that generally help women with the pain?
Are you talking about general pain or chronic pelvic pain?
I think general pelvic pain.
Or no, general chronic pain everywhere and say in the pelvic pain.
Yeah.
Unfortunately, there are a number of studies shows that if I just go back just very quickly, I describe the number of the painkillers we have. Maybe people who are listening to this would be interested to know.
Yeah.
Okay? In pain medicine, or generally in medicine, we have two completely different groups of the painkillers. One group for headache, joint pain, back pain, period pain and all that. And they are generally like a pyramid, starting from the simply paracetamol, ibuprofen, diclofenac, that sort of thing. You go one higher, probably cocodamol, codidromol, tramadol, then morphine patch, and then morphine. These are generally for more of the musculoskeletal, for that sort of pain. There are a group and the number of the medications who are specifically to relieve pain arising from the nerves. And the pain arriving from the nerves are generally shooting pain, burning pain, stabbing pain, pins and needles. And a lot of patients with the chronic pelvic pain have that sort of sensations within the vulva, vagina. And it is good to talk about probably men also. They have this sort of sensations in scrotum or penis. These group of the medications are commonly prescribed for the chronic pelvic pain. Number of studies has showed that the opioids and even non-steroidal anti-inflammatory drugs like ibuprofen and all that are not very effective. And also just remind you that these medications, say like non-steroidal, in the long term have a quite significant negative impact on the kidneys, on the stomach. And also because the chronic pelvic pain is very common among the reproductive ages, giving them an opioid, there is a significant danger of the addiction. And also many of these patients cannot tolerate opioid because of the nausea, vomiting, constipations, and dizziness, drowsiness. So it is not just like a Smarties that you can take and the pain goes away. So coming back to the second group, which I mentioned, which are the medications related to the nerve, yes, some of them are effective, but still these medications have significant side effects. That's why I'm going back to what I started, that it is not just one size fits all. It is not just simply either do the laparoscopy, which I'm going to talk about, one treatment that it is very common for the endometriosis considered by gynecologists chronic pelvic pain. But that's why it has to be factorial cause of the pain. It should be treated by the number of the specialties rather than one. As I mentioned, generally and traditionally, endometriosis is diagnosed by laparoscopy.
Yeah.
There are 250,000 laparoscopies are done in the UK to either diagnose or treat endometriosis. Based on the report of the Royal College of the Gynecologists, half of them, they don't find any pathology or cause to explain the pain. So now you're talking about 100,000 women who have started this journey to have some pain relief of the chronic pelvic pain, which they have no actually cause, or they have no pathology because the endometriosis was negative. So these patients, what happens to them? Generally, there was a study done in 1999, which I believe that still it is there. There are four line of that happens. One, most of these patients are told that there is nothing wrong with them. Mm-hmm. Unfortunately, they are told that pain is in their head. They are referred back to the GPs or the foreown, and they are prescribed generally one of those medications, the painkillers that are. None of these measures actually provide any meaning for pain relief. And most of these patients, even, first of all, it takes about 8 to 10 years before these women do reach to the point that they see a specialist. That could be gynecologist, urologist, pain clinic, never. So that's one. Other side of it, which unfortunately doesn't come to the fore, is that out of the, as I mentioned, the 250,000 laparoscopies, there are 21 deaths every year for laparoscopy and 500 significant and quite complicated, complications. So it is not completely safe. Although it is safe, but even 21, that is a lot. And the American College of the Gynecology and Obstetrics in 2015 recommended that no woman should have laparoscopy until they have musculoskeletally being examined, because a lot of these women have a musculoskeletal pain which could be treated. Once, if it doesn't reach anywhere, then probably laparoscopy, because it is a surgery. And unfortunately, in that last 20 years, I have come across many cases. The women have seen 4 or 5 gynecologists, have had 5 laparoscopies with no outcome at the end of it. And each one of these has made the patients more disappointed, and we will come to that, but hopefully to discuss that, what happens to them. I am not attacking gynecologists. There are a lot of good gynecologists that I work with them who are very conscious about this, and they look at the holistic way of it. I'm just hoping to start a debate about, is chronic pelvic pain only endometriosis? Mm-hmm. If you look at even charities in England, most of them, they are called Endometriosis UK, not chronic pelvic pain. Mm-hmm. I'm hoping that we step back and start from the point of what is chronic pelvic pain and how could we help these women who are in so much pain.
So you kind of mentioned there that the musculoskeletal kind of assessment should probably be done before we kind of go gynecologically. What does that assessment look like?
Megan, that is probably what I said, but what I meant not before. I think I'm hoping in ideal world that the woman will be seen from the word go by gynecologists or urologists, depending on their symptoms, pain consultants, as well as the physiotherapists and psychologists. Depend on if there is sort of triaging system that you look at. You have more of the gynecological issues, so it is gynecologist, but your symptoms doesn't look entirely endometriosis. So we might get a help from the pain clinic or from this. Can I have a look at my close friend and say why I think that the musculoskeletal part is so important for the pelvic pain?
Yeah.
Human being. We are the only living organism or creature or things that we stand upright and we walk on two. We are the only one. And in order to achieve that, our spine, our pelvis has undergone significant changes, evolution of million years of that. One of the reasons, if you look at our spine, it's S-shaped. And why is this S-shaped? Because our weight, main part of our weight is torso. The greater part of our load actually falls around here, just upper part of the back of the pelvis. So that is very important. And that S-shape maintains that falls here. Second one is the significant importance of this joint, which is called sacroiliac joint. It is the joint between the bone which has got a tailbone and the rest of the pelvis. Without function of this joint, we won't be able to sit or stand.
Oh, wow.
So when we sit or stand, generally the pelvis locks in, and actually when you see that, it turns down. So this pelvis and the bones, it rotates slightly backward and locks. The knee extends, and that's why we can stand and walk. So, and this is something we do how many 100 times a day?
Oh, yeah.
A lot.
Without thinking.
So patients who have chronic pelvic pain, obviously because of the impact of the pain, there is overload of the muscles, joints, and actually tendons within this area. So what happens? Initially, the muscle overwork, tendons overwork, the joint, sacroiliac joint overworks and compensate. But after some time, the overload is so much, actually there is a dysfunction of this movement, this function. And that also becomes perpetuating factor for the chronic pelvic pain. This is specifically important and relevant in chronic pelvic pain of a woman during and after pregnancy. Remember what I said, that this movement, this unfortunately in about 6% of the women during and after pregnancy, dysfunction, this movement becomes abnormal. And this woman have a significant pain within the pelvis, over the lower abdomen and over the buttock, which some of them are unable to do any exercises or walk. If it is taken as endometriosis and going to that line, it is completely lost. So this is one. Let me put my friend down. The other will be, as I mentioned, the effect or the role of the nerves. I have come across many women or men with rectal pain, with the vulval, vaginal pain, clitoral pain, or in case of men, with the testicular and the penile pain. And this is a subgroup of the chronic pelvic pain, which generally very much related to the nerve called pudendal nerve. Going back again, the pudendal nerve comes from the three small nerves within the pelvis. It goes through the pelvis and supplies those areas. There are a number of the reasons that the pudendal nerve could be irritated. Professional cyclists, people who sit for a long period of time, sedentary work, fall, trauma, childbirth, if there is any trauma. It generally irritates the pudendal nerve, and this pudendal nerve causes the pain, which, as I mentioned, this is a different pain of burning sensations, shooting pain, stabbing pain, pins and needles within reproductive organs and area. There is quite effective way of injecting around the pudendal nerve under X-ray or CT guidance or ultrasound, which helps many patients for a number of months, could be reducing those pains.
And I guess to kind of wrap up a little bit there, one thing I'd kind of like to ask for our audience is, if you are suffering from chronic pelvic pain, how do you advocate for yourself? Do you have any tips for people?
Yes. First of all, come out of it and don't accept that the chronic pelvic pain means endometriosis. This is wrong. The chronic pelvic pain has a great part with the muscles, joints, nerves, endometriosis, issues with the bladder, and also with the bowel. So considering this and asking to be treated holistically, keeping an eye with all these elements and being treated by multidisciplinary approach, including gynecologists, urologists, gastroenterologists, consultant in pain medicine, and also physiotherapists and psychologists. If the approach is that from the very beginning, the outcome and the impact of the pain on the woman's life will be much less. Unfortunately, because we don't know the actual cause of the lot of chronic pains, including chronic pelvic pain, the cure is not there. It has to be taken as a long-term symptoms, syndrome, that it needs long-term looking after, not by one specialty, but by many specialties in collaboration with each other. That is a demand has to come from women. Probably women's power coming forward. If they believe in what I say, researching this and looking around at rest of the world, in America, in Europe and other parts, how this multidisciplinary has enabled women to reduce the impact of pain and improve their quality of life. I think most women, once they have pain for a number of years, they realize that it's not going to go away. But when they come to my clinic, many of them, they want improvement in their quality of life. They want something that it could help their relationship. And the most importantly, they want someone to explain to them what's wrong with them, what's happening with them in frank and honest way, and tell them that, look, this is something you will probably live with it for all your life, but there are measures we can reduce the impact of it on their life.
Well, Dr. Khaled, you've given me a lot to kind of think about here, and there's been a really, really interesting conversation. I feel like we could talk for hours about this, but thank you so much for your time. I think it's such an important topic to kind of get out there. I really appreciate you coming on the podcast.
My absolute pleasure. Thank you so much for giving me the opportunity to speak about this. This is something that I have been trying to bring it to the fore for the last 20 years, and I'm hoping that that could be a small step toward that.
We hope.